Dr. Catherine Ray, who's going to give us a hematologist perspective on why VWD is undertreated versus haemophilia. Catherine is also the Vice President of Clinical Research at Hemab Therapeutics, and I'd like to pass over to you now, Catherine. Thanks.
Thanks, Kat, and hi everyone. It's so lovely to see you all, and thank you for joining. So as Kat said, yes, I work for Hemab Therapeutics, and I'm working with them to develop a new drug in von Willebrand disease. But more importantly, I'm a doctor, and I've been working with patients with bleeding disorders for quite a number of years. The reason I'm with Hemab Therapeutics is because I'm a frustrated doctor who is quite tired of sitting in clinic and telling patients with rare bleeding disorders of von Willebrand disease that I don't have better options. So it is great to be part of a community like this and an event like this, and to start to see the von Willebrand community start generate a strong voice, because I think that is really needed. Next slide, please, Kat. So Kat and the team have given me some really weighty questions to try and tackle in the next 10 to 15 minutes, and I can't promise to do this justice. I will speak in quite general terms when I'm answering these questions, and I'm based in the UK, so some of it might be quite UK-centric. I also acknowledge that the von Willebrand disease community is really diverse. You all have quite unique symptoms, stories, and experiences. So I won't be able to reflect all of these in my answers, and forgive me in advance. But I think that's one of the key challenges for this community, in a way, that you have a diversity of experiences, needs, unmet needs. And how are we going to come together to find a very clear voice that makes the demands that are needed? And I hope that's something we can explore together when we get to the question and answer session. But I will start and give my best to tackle these weighty questions. And I'm going to start by saying I've changed your questions, actually, Kat, because I don't think von Willebrand disease is just undertreated compared to haemophilia. I think that you are underserved in almost every aspect of care. And I'd like to take a little bit of time on the next couple of slides to explain what I mean by that. So if you don't mind going to the next slide, I think there's a critical problem with von Willebrand disease in terms of diagnosis and beyond diagnosis, recognition. So I bet if we do a show of hands here, there'll be quite a number of you that waited many years for a diagnosis of von Willebrand disease, and went probably around in circles to doctors saying, no, there's really something quite wrong, and had multiple blood tests before somebody actually recognized the symptoms and put it together, or actually paid enough attention to do those diagnostics. And I think many doctors don't recognize von Willebrand disease quickly enough. And on top of that, I don't think they recognize the impact of the symptoms. So you can be quickly dismissed as just having a bit of a nosebleed problem, or just having a bit of heavy menstrual bleeding. And I think we get into the situation where patients quickly learn to live with it. You're told that things are normal when they really aren't. And that's where there's the underdiagnosis, but also the under-recognition and the normalization. Now, sometimes I really do appreciate that when there are no good options for treatment, this can be quite a helpful psychological approach. It can be quite empowering to go, yeah, okay, I've got symptoms that are normal for me and I know how to deal with it, and you just get on with it. But unfortunately, I think this has become a little bit of a lazy default position where we say, it's fine, it's normal for you, off you go, and we don't strive to do better for the individual. So that, I think, is the diagnostic and recognition challenge. Then, if you are lucky enough to get your diagnosis, certainly in the UK and other countries, I know this is reflected in your healthcare systems as well. I think there is really poor and inconsistently coordinated health infrastructure. So often people don't have a specialist they can go to, or it's very patchy between areas. Somewhere it's a really clear service, but in many places you have your diagnosis, but who do you actually turn to at the point that you need care, at the point that you need those services? And I think we could do a lot better in recognizing the need for oversight, access, and conversation with patients. And then on top of that, all of this leads into very limited treatment options. So at the moment, we have restricted access to the existing therapies. As Kat mentioned, we have insufficient drug innovation specifically targeted for von Willebrand disease, and I'll go through some reasons, in my opinion, for that in the next slide. But on top of all of this, I think we really just have a good enough mentality. We have treatments that can plug the gaps, as Kat said. We have things that can stop bleeding, and it's led to the situation where we go, okay, well, we've got something that sort of works, that's good enough. But I don't want to see that. I don't want to see people just coping. I think we really need some tailor-made drugs to suit all the different types of people with von Willebrand disease, their different patterns of bleeding and their different needs, as we have in haemophilia, where there are multiple options for treatments that can be adapted to suit different people's requirements. So that is my rationale for saying I don't think you're just undertreated. I think being unrecognised, totally underserved, that leads to the lack of treatment development that we've been seeing. So next slide, please. So Kat, your next question really was, well, why is that the case? Why can we look at the amazing innovation that's happened in von Willebrand disease over the last 30 years? And it really is impressive. Why has that difference occurred? And there are quite a few complex interconnecting reasons, in my opinion, and I'll try and take you through them in some sort of order. But one thing I think is the clinical presentation. As I said at the beginning, in von Willebrand disease, it really is diverse and highly complex. Whereas in haemophilia, there's quite a visible, clear bleeding type. So people with haemophilia classically present with painful swollen joint bleeds. They're very easy for your simple doctor to see and understand why that has an impact and why that really needs intervention for that little boy who's turned up with their joint bleed. Now, some patients with von Willebrand disease certainly experience those sorts of symptoms, but that's a small number of the group. Most people have a highly complex mix of bleeds, and they're not always that visible. So I have patients who actually have had really quite severe anemia because they're having multiple small volume bleeds, and we really struggle to get on top of that. And I think unless you sit down and really talk to the patient about the volume of the bleeds they're having an impact, it's really easy to miss and to not recognize those symptoms sufficiently. So as I said, haemophilia, it's a very small, well-defined, well-demarcated group. Von Willebrand represents a much more diverse, complex, larger group of patients. So immediately it's more difficult for us to tackle because of the diversity. Beyond that, I also think there's a historical perspective and a medical perspective. I admitted to the VWD Alliance that I looked at my medical notes from medical school, and I'm embarrassed to say that I do have it written down that haemophilia is a severe bleeding disorder, von Willebrand is a mild bleeding disorder, except for the few cases that behave like a haemophilia patient. And I'm afraid that is quite pervasive. I've obviously now met lots of people with von Willebrand, and I've been in this field for a long time. But that is something that's going to be, if that's in medical education, that is going to be slow to change. And to be honest, we were at a conference recently, Jigger and I, and we still heard medical professionals saying things like, well, it's only the guys that have haemophilia type symptoms who need treatment. So it's deeply embedded. And people don't say things like that because they don't care. It's because that's what you've been told, and that's what you kind of grew up through your medical career recognizing. So I think that's a really important point, education you need to ingest. I also believe there is a gender bias. We know from research that there is a gender bias in diagnosis and care for female patients. Boys are affected with haemophilia, and it may well not be an overt or intentional bias, but menstrual bleeding is trivialized. And so I think there's a gender bias in terms of diagnosis and care. People are told heavy periods, they're normal, grit your teeth and get on with it. And I've heard people tell me that just a tragic number of times. Then there's also the element of community mobilization, which is why I'm so happy that we're at this meeting today, because I think this is a really key point. The really tragic infected blood scandal, which we experienced in the UK and of course globally, it affected almost every member of the haemophilia community, and the community was quite rightly mobilized and very angry and had a unified voice absolutely demanding that those responsible do better. And in response, physicians, researchers recognized that they had in my opinion, that they had the obligation to do better. And the result of that has been a group of people with a very clear and united voice, and physicians and researchers who are very engaged in battling a problem together in a united way. That has led to the innovations in partnership and collaboration, with patients telling us what they need and what they expect, and us responding to it in a timely and motivated way. Now, with that has grown the recognition that they need to have good infrastructure. So we have purpose-built therapies, but also purpose-built systems to deliver those therapies. And on top of that, a really well-educated, motivated vocal group who expect tailored, timely, specialist care and treatment from birth. And they expect options that will suit them and their symptoms and their stage of life. Now, conversely, you have the von Willebrand disease community, which is larger, diverse. Now, some people were certainly infected and impacted horribly by the infected blood scandal, but that's not the same sort of ubiquitous experience. So you didn't have quite the same motivation to really come together with a strong voice. And as such, I think that's been an important reason why we've been able to slightly ignore the von Willebrand disease community. And it's resulted in a lower priority for your care, a lower priority for your drug development, fragmented pathways. And I think going back to this idea about being told that it's all normal, just get on with it, you guys have quite a low expectation, I think, sadly, for what you should be able to expect. You don't get von Willebrand disease patients, people who are affected having babies and coming and saying, right, I need a care plan. My little one is about to start toddling around. What are we going to do about this? Where is the pathway? And what are his options or her options going forward? So in order to move forward, I think together we need to recognize and address all of these elements to really drive better options, better care, and the optionality that people with a bleeding disorder deserve. So let's move to the next slide for my next tricky question to try and finish off in a couple of minutes. And that was, Kat, you asked, should prophylaxis, so should preventative treatment be limited for those with the most severe symptoms? And I think when you got my slides, you probably went, huh? Because the response was yes, I think we should. And retain treatment for those with the most severe symptoms. You don't want to treat people who don't require treatment. But I think we urgently need to redefine severe symptoms and how we think about severe symptoms, because currently there's a real hangover with thinking about severe symptoms as resembling only haemophilia bleeding. And it focuses on, recurrent joint bleeds. And I don't mean to belittle anyone in the group who has recurrent joint bleeds. They are horrible. You absolutely deserve the best level of treatment. But I don't think we should stop there. I think we need to consider the impacts. For example, my patient who has recurrent small bleeds, that they come to me and say, oh, I've had 3 bleeding episodes yesterday, and I look at them and go, well, you're not bleeding, but it turns out they're chronically iron deficient. It means they're exhausted. There are all sorts of physiological impacts on that. I think that's a really difficult situation to live with. Then there's heavy menstrual bleeding, and yes, oral contraceptive pill can be great for many people. It's not great for everyone. The 12-year-old, the 11, 12-year-old being put on the pill, it is really difficult. And I think that heavy menstrual bleeding that is affecting your day-to-day life is a severe bleeding situation. On top of that, I think there's this need to have multiple bleeds in the guidelines at the moment. You have to have frequent severe bleeds to prove that you deserve prophylaxis. And to me, that seems crazy. If you have had one major bleed that has been life-threatening, admitted you to hospital, been traumatic, you're going to go home still with von Willebrand disease. And I would love to be able to give you something that reduces your risk going forward so that you can reduce your anxiety and have the option of having a lower risk of that happening in the future. So I think in summary, what I'm saying is that it's not really about restricting treatment to severe patients. That's not the way to go. I think the problem is that we don't have the options that will allow us to treat all the people with severe bleedings as per my definition. And I can understand at the moment why we do restrict treatment to a certain extent, because prophylaxis is IV factor concentrate, and Emma can talk to it in a minute. I know it's a really good option for a lot of people, but it is extremely daunting when you're standing there, you know, being offered IV prophylaxis that will go on, and you need all that training. It is a big step to take and not practical for many patients. So with my expanded definition, what I want is better solutions that can fit other people's treatment patterns, other people's needs. And I think we need to work together to demand better recognition, better infrastructure, and optionality for the different symptoms, the different experiences that this community has. So I think I took well over my 10 allotted minutes. I apologize, but as I said at the beginning, I'm a very frustrated doctor who has had to have the horrible conversations with people in clinic who've looked at me and said, okay, what's the next step then? This isn't working for me. And I've honestly had to say, I'm sorry, but that's it. And I really hope that together I won't have to have many more of those conversations. So thank you for your time, and I'll look forward to your questions a little bit later.
Thank you so much, Catherine. And there's absolutely, honestly, we'd love to hear from you for as much time as you need. So yeah, thank you for covering those points. I think it's fantastic. As Catherine mentioned, if you have any questions, please include them in the Q&A chat box, and we will go through them all at the end in the final session.